evening, everyone, and welcome to today's wonderful evening. We have Dr. Dhairya. 1 minute. I think Dr. Dhairya has just logged out. He will be logging in once more. Yes.
Hello.
Yeah.
I'm
Hi, Dhairya.
I'm really sorry. My internet just crashed for a minute. I'm really sorry.
Yeah. So it's wonderful to have all of you for today's evening. The most awaited session of teacher versus topper. We have Dr. Dhairya. Dhairya is, as you all know, in the last session, one of the most brilliant MD general medicine, the general medicine resident from, he graduated from the prestigious JJ Hospital. And the last session, we had a lot of case study based questions, similar to USMLE style questions. And today, Dr. Dhairya could give his time for us to once more have a quick teacher versus topper session. Good to see Dr. Keerthu and many more who are all online. Please inform your classmates. Every day we have this teacher versus topper. Our two teachers having a fireside chat. And one more session we are introducing shortly. About 7 to 8 NEET PG aspirants and myself. We will log in together. That is called as combined study group discussion. We will take 200 questions and we'll go on a rapid fire. One after other, we will throw the questions. And these 8 to 9 students who are there in the session will start punching the answers. That way, what happens is, Spardaya, Vardhathey, Vidya. Together, when we study, when we meet and study together, it's a joy, right? That's an interesting way of doing the revision. So let us see Dr. Dhairya, a 5-side rapid fire session, and we will try to finish at least 50 important topics in a very fast way. So let's make the great beginning, Doctor.
Good evening, everybody.
One minute.
Yeah, absolutely.
Yeah. Got it.
This patient is complaining of when we can see that he looks like a scleroderma. There is ulcers on the fingers. There is gangrene. There is what appears to be facial involvement. So so you could call that a heliotrope rash. This is scleroderma. Immune marker is SCL70. That's scleroderma 70, and so I think scleroderma, you have to differentiate it from Crest syndrome, which is calcinosis cutis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. And
very good. And the specific marker for scleroderma will be anti-topomerase 1, which is highly specific for the scleroderma. It's also called SCL70 antibody is what we need to remember. A lot of times we give D-penicillamine, but D-penicillamine is one of the dirtiest drug that I have ever prescribed to the patients. A lot of side effects. And one important reason why scleroderma patients die is a very important question.
That is the scleroderma renal crisis. A patient presents in renal crisis, he will have very severe hypertension. He can have hemolytic anemia. He can have hypertensive encephalopathy. Very emergent treatment is required in an ICU probably. So encephalopathy and
yes. So Eosinophilic is considered to be the drug of choice to treat the renal hypertension, which is seen in the case of the scleroderma. Very good. So, doctor, what is this condition and what is the diagnosis which is associated with anti-RNP positivity?
So now, firstly this condition. Now this condition, you can see that there is a pallor of the distal digits, and in the second, you can see that the similar condition is involved with cyanosis. This is clear Raynaud's phenomenon. It could be either primary or secondary. Now, when anti-RNP positivity is involved, it is a secondary Raynaud's due to autoimmune diseases. So anti-RNP, I think it's a marker for mixed connective tissue disorder.
Very good. So the mixed connective tissue disorder has the features. Why it's called mixed? It is because of the SLE plus scleroderma and the polymyositis. All these features will be there. And anti-RNP is considered to be 100% specific for the mixed connective tissue disorder. Is one of the favorite questions of the examiner. And just the way we treat the SLE or rheumatoid arthritis, we give NSAIDs, antimalarials like hydroxychloroquine S, hydroxychloroquine sulfate 200 milligrams, and low dose prednisolone, methotrexate, etc., are being given in case of the mixed connective tissue disorder. Now, what are the important features on immunofluorescence and the histopathology and the clinical presentation, and what is your diagnosis, doctor?
So now this dry tongue, furrowed tongue is very classical of Sjogren syndrome. I don't actually understand the fluorescent microscopy. I'm sorry, but the image given on the left is very classical.
Very good. Actually, whenever you see a histopathological picture like this, all these blue dots that you are seeing, they are all lymphocytes. So basically, this is a salivary gland, and there is a lymphocytic infiltration into the salivary gland, leading to the destruction of the salivary gland. So if the salivary gland is destroyed, what will happen? There is a decrease in saliva. If there is a decrease in saliva, there is a drying of the tongue. So this is how typically with a fissured appearance of the tongue, the patients of the Sjogren syndrome typically present. And one more important thing is dental caries is the presenting feature. I have one of my patients called Lakshmi, who comes from a village. She is the wife of a farmer. So when she came with dental caries, generally dental caries means somebody eats chocolates. It's more common with the urban living. So what is the reason for the dental caries in a Lakshmi? But Lakshmi also has joint pains, and that was the first case during my MD where I have done labial biopsy, that is underneath the tongue, sublingual glands, salivary glands, biopsy was done, and I still remember sitting with my pathology professor and watching the slide of the lymphocytic infiltration into the salivary glands leading to the destruction. And this immunofluorescence is called speckled pattern of immunofluorescence is what we need to remember. And that is the diagnosis of Sjogren's. And one important thing we need to remember is whenever Sjogren happen to affect kidney, renal involvement, there are two ways by which kidney get affected. One is it directly damages the tubule, so it leads to tubulo-interstitial involvement. Second is it also can involve the glomerulus. So both the things it can be able to do. So it can present like a glomerulonephritic picture, or it can be even tubulo-interstitial kind of a pathological presentation is what we need to remember. Now, what is this clinical presentation, doctor, and what is the diagnosis and a couple of points about it?
So now this patient is coming with livedo reticularis, if I'm not mistaken, the purple colored involvement. Considering this patient, it looks like an APLA syndrome. That is a antiphospholipid antibody. Patient will come with recurrent pregnancy losses. Patient will also have hypercoagulability of blood. Patient comes in deep venous thrombosis, sometimes comes in frank DVT. I think that's about
Very
it.
good. So one of the challenges in APLA syndrome, antiphospholipid antibody syndrome, Once more, Kirtu, Dr. Pramod Gurjar, Dr. Rishabh Shetty, and many more who are all online. Let us make learning together a practice. Because ultimately tomorrow when you become consultants after finishing your MD, life is all about not practicing alone. It is about a pathologist will talk about the case, a pulmonologist will talk about a case, a intensive care anesthetist will talk about the case, and you also will talk about the case. And ultimately, you will do the best what the patient requires. So that is the reason most of our clinical practice is a conglomerate of all the subspecialties coming together, just like all forces of the nature come together, the patient will not die. So that is the reason from now only, during preparation days only, let us, instead of making it a solo sitting in a reading room and mugging, or attending a didactic lecture of a video of some teacher who is boring us. Instead of that, let us become group. Let us put some points that come to our mind. At least a couple of hours, let us inspire each other every day. And that is the whole purpose of this teacher versus topper, teacher and NEET PG aspirants together as a group study. All these sessions on your favorite YouTube channel. Please don't forget to subscribe and also share this YouTube channel with all your classmates. So, doctor, we need to remember one important challenge in the APLA syndrome. What happens in APLA syndrome? Patient has got a thrombotic tendency. So how do you treat thrombotic tendency? You need to
Anticoagulants. Anticoagulants.
Anticoagulant. But to give anticoagulant, what is the challenge?
Now the problem is that APLA does not actually respond to Novax, so you have to give warfarin. But in order to give warfarin, the problem would be that you get a acute protein C and protein S deficiency, thus precipitating further thrombosis in the acute stage. So you have to overlap warfarin.
That is one point. One more point is APLA syndrome. There is a laboratory-wise a prolongation of APTT in the lab. But actually, patient does not have a real APTT. In vivo, APTT is normal. But in vitro, APTT, in the lab value will be about normally APTT, suppose if it is 35. The patient will show 120, 130, 140 like that. So to a patient with such a prolonged APTT, to provide anticoagulation with heparin becomes a challenge. Of course, you don't need to monitor APTT if you are giving low molecular weight heparin. But in spite of that, whenever you need to give heparin to a patient who has got an APLA syndrome, one of the big challenges is APLA by itself lead to a significant prolongation of the APTT in vitro is what you need to basically remember. That's great. Now, doctor, what is this connective tissue disorder?
So this patient is coming with rashes on the knuckles, very classical cotton papules. And on top of that, patient is also having what I would assume is a heliotrope rash. These two features together very much diagnostic. So the patient has dermatomyositis.
Very good. So does dermatomyositis lead to a proximal muscle weakness or a distal muscle weakness, doctor?
I honestly don't know. I'm sorry.
No worries. So see, there are two things. One are myopathies, other are called neuropathies.
Yeah.
Ideally, we should be not getting any of them. If we get any of them, we need to pray Tirupati. Myopathy versus neuropathy. What is the difference in weakness? Myopathies lead to proximal muscle weakness. Please remember, myopathies lead to proximal. What are proximal? Shoulders are proximal muscles. Hip joint is a proximal muscle, right? Whereas neuropathies lead to development of distal muscle weakness. Distal muscle weakness. What is a distal muscle? Your fingers are distal muscle. Your toes of the feet are distal muscle. So how will be the clinical presentation of a patient of proximal myopathy? A proximal myopathy patient will say, oh doctor, I have gone to this, in Telugu we call parentum. Parentum means it is like all the people come together on a religious festival. So yeah, all the people will be sitting on the floor on the floor. So to get up from a squatting position, if the proximal myopathy is there, to get up from a squatting position becomes challenge. So that is the reason I still remember one of my favorite patient, Annapurna. Annapurna is a very religious lady. So she has a difficulty to get up from the squatting position. Kirtu rightly says, Grover's sign is also one of the classical examples. So myopathies lead to proximal muscle weakness, whereas neuropathies lead to distal muscle weakness. Distal muscle weakness means a lady will say, "Oh, I love my husband so much, but of late I'm unable to sew his sweater. She is weaving his sweater. She is unable to do that because for that you require the coordination of fingers." Similarly, the patient will say, "My father is walking, but he is having tripping attacks and falling down." Because what type of muscle weakness? Distal muscle weakness. So in summary, you need to remember that typically the proximal muscle weakness lead to is seen in myopathy. So dermatomyositis patients will have, why this is called heliotrope rash actually? Heliotrope is flower. So heliotrope, the color of the flower typically will be like this. That's the reason it is called heliotrope rash. So as our Dhairya rightly said, a very important point that so he already told the important point that in case of polymyositis we get Gottren's papules. Then another very important point you should remember, doctor. The most sensitive test in polymyositis is CPK.
CPK of the MM kind.
Correct. But there is one challenge. One challenge in managing these patients, real clinical scenario. When a patient of dermatomyositis comes, what is the treatment? We have to give her steroid. But there is an entity called steroid-induced myopathy. Steroid-induced myopathy. So a lot of times we don't know in a patient to whom we started steroid, is it because of the worsening of her underlying problem of polymyositis, dermatomyositis, or whether it is steroid-induced myopathy. So how you will be able to know that? In that case, you need to take the help of anti-Sjogren antibodies, number one. And another important point is, a high CPK is not a proof of polymyositis, dermatomyositis. It is not a proof. By CPK elevated high बोल के उसको polymyositis, dermatomyositis नहीं बोल सकते. CPK is only used to rule out whether the given muscle weakness is because or not. Suppose if somebody has a muscle weakness but CPK normal, then it is unlikely to be due to polymyositis, dermatomyositis, but it does not prove. If you want to prove, you also need to show the anti-Sjogren antibodies. Similarly, on EMG, you will see the presence of fibrillations. That is the point you need to appreciate. Now, doctor, what is this vasculitis?
So this is a very, very classical picture. This patient is coming with a very prominent temporal artery. Patient will come with headache. Patient might have unilateral blood blindness. This is very easy giant cell arteritis. On the histology, you can see a giant cell marked with the arrow. And the problem with this is that you have to give instant steroids to the patient. As soon as you suspect giant cell arteritis, you have to initiate steroid. The main point is that steroids will prevent blindness in this patient. So you have to save the eye. The definitive diagnosis will definitely be via arterial biopsy, but that can be done later as well. And the diagnostic histological features are not lost by steroids immediately. So you have to start steroids and then plan for a biopsy. Do not wait for a biopsy before starting steroids.
Very good point. And high ESR, elderly person presenting with throbbing headache, classical of temporal arteritis is what you need to remember. Now, doctor, let us see this clinical case. This is a child recently had an upper respiratory infection about a couple of days ago, and post infection, the child has developed these lesions. They are very much palpable lesions, which you are seeing in this child. So now the question is, what is the diagnosis and what is the treatment for this given scenario? Yes,
So
Dr.
now
Dhairya.
there are very few causes of palpable purpura. One would be your Hinox-Conlin purpura, another would be a thrombotic thrombocytopenic purpura. So in this case, after upper respiratory infection, and especially in a child, you would think of an HSP, that is mediated via IgA. Inox-Conlin purpura would be the answer. So for this patient, usually you don't have to treat steroids, maybe, but other than that, it's self-limiting mostly.
Very good, doctor. Now the next question is, this patient's arteriogram is being presented to you. What is that one characteristic feature and what is this vasculitis?
So you can see these arterial nodules that are marked with the arrows. Yeah, this is just polyarteritis nodosa. Very easy to diagnose. PAN. So
Yeah. So one important point we need to remember, frequently asked in the entrance is, PAN is medium-sized arteries, immune complex mediated hypersensitivity, hepatitis B, hepatitis C, seropositivity is very characteristic. A good number of times even HIV is being found, and diagnosis is basically confirmed by the biopsy, and there is a elevated ESR is very important, and typically the polyarteritis nodosa need to be differentiated from that of the most important differential diagnosis, microscopic polyangiitis. We will come to the difference between the two. But all of you remember, without a question on vasculitis, Dr. Dhairya, will there be any NEET PG entrance without vasculitis?
absolutely not. Absolutely not. So there are these giant cell arteritis. There is medium vessel vasculitis. There are microangiopathic vasculitis. All of them are always asked. The good thing is that these are all very theoretical questions and very specific points are asked from each vasculitis. So you don't have to remember everything in detail. You just have to remember the main features of each disease. I think that should be
Yes,
more than enough for
absolutely.
MCQs.
One of the favorite questions of the examiner is, what are large vessel, what are medium vessel, what are small vessel? A very
Absolutely.
easy way to remember is giant cell arteritis and
And
Takayasu
Takayas.
arteritis. Because this is arch of aorta involvement, easy to remember, large vessel. Then medium vessel. Medium vessel, you can remember Kawasaki disease. How will you remember Kawasaki? Kawasaki is a bike. एक बाइक होता है, लॉरी नहीं, सो इसलिए लार्ज नहीं है. एक बाइक होता है, बाइसिकल नहीं, इसलिए वो स्मॉल नहीं. तो बाइक होता है मीडियम साइज वाला, इसलिए कावासाकी होता है मीडियम साइज वाला. And everything else, HS purpura, blah blah blah, everything falls into the small vessel
Small.
vasculitis, is what you need to remember. Now, what is this you are seeing? What is your diagnosis and comments about
this
this, doctor?
this patient has come with the destruction of his nasal septum. The CT scan is showing that the patient also has destruction of the upper palate. So this is very classical of granulomatosis with polyangiitis, also known as Wegener's granulomatosis. It won't be asked as Wegener's granulomatosis anymore because that name has been discontinued. To That's about it. Wegener's granulomatosis.
Very good. So
Remember it as granulomatosis with polyangiitis. That's a better name for this disease now.
absolutely. So upper respiratory, lower respiratory, and renal involvement together. That is a highlight. So a lot of times patients go to ENT surgeon because they are having recurrent attacks of sinopulmonary involvement. So upper respiratory. Then lower respiratory. In the lung, they are having a cavitating lesion. That's the reason they present with hemoptysis. And in the kidney, they present with hematuria. So this is the combination that you find. What is the most common differential diagnosis for the vaginal doctor? Typically, most common in India.
So in India, you would see tuberculosis as a very common diagnostic factor. Another problem is that both of them will have granulomas on histology. So that's also one more problem, and both of them present very similarly with upper and lower respiratory involvement. At the same time, TB may also have renal involvement, and the presentation is very much similar.
Very good. So Sianka positivity is classical feature. We give high dose steroids, cytotoxic agents like methotrexate, cyclophosphamide, rituximab. They are the ones which are basically offered as a treatment. And necrotizing vasculitis of small to medium sized vessels is the description of vaginal granulomatosis. Now, what is the most common cause? Actually, this condition which you are seeing here, this is the most common cause of pulmonary renal syndrome. Generally, we think pulmonary renal syndrome means most common cause is vaginal. No, it is not vaginal. This condition which you are seeing here is the most common cause of the pulmonary renal syndrome. So what is this condition, doctor?
This is microscopic polyangiitis. Basically, you can see that this patient is having manifestations in smaller vessels. You can see that the biopsy is showing involvement. There is it's called a ground glass appearance in the histology, if I'm not mistaken. And microscopic polyangiitis, P ANCA positive, as compared to vaginal, which would be C ANCA positive. And,
right.
Yeah.
So non-granulomatous necrotizing vasculitis, which is the cause of the pulmonary renal syndrome. Even good posture can also cause both kidney and pulmonary involvement because of the anti-GBM antibodies. And typically, microscopic polyangiitis involves small and medium-sized arteries, veins, and also capillaries. And that is the reason it is a very close differential diagnosis to polyarteritis nodosa. And renal vascular involvement can lead to the development of hematuria, is what we need to remember. Now, this is allergic angiomatosis and polyangiitis. Allergic is very important too. So, what is your diagnosis, doctor?
So now allergic would point you towards an eosinophilic condition. You can see the histology that they are marking these eosinophilic this thing. So this is just diagnostic of eosinophilic granulomatosis with polyangiitis, previously known as Church-Strauss disease.
Right, Church-Strauss disease. And typically there will be asthma and pulmonary infiltrates, typically which are fleeting in nature. There is a rash and significant dysnophilia. And biopsy is considered to be most accurate. P-ANCA positivity, and we give corticosteroids and cyclophosphamide is what we need to remember. Now, this vasculitis in a young, sweet-looking female from Asia, presenting with hypertension, and one of the radial artery is showing pulselessness. So, what is your diagnosis, doctor?
Takayasu arteritis. Start.
Yes. Any points on this?
Yeah, so you can see that one of the arteries of the arms is narrowed, which has been pointed at. That is what causes pulselessness in Takayasu arteritis. This is also a very important disease to think about in a young person. A similar presentation with difference in blood pressure in right and left upper limb was discussed last time. That would be an aortic dissection. However, aortic dissection would be acute, and this would come over a longer period of time. Takayasu arteritis.
Very good. So typically patients can have symptoms like fever, night sweats, malaise or arthralgias, and arteriogram will give you the diagnosis. We give steroids, antihypertensive therapy to relieve the symptoms, and also methotrexate, azathioprine, etc., etc. Now, in this patient, you are seeing a very. Is the video clear, Dr. Dhairya?
Yes, sir.
Yeah. So you are able to see in this patient a gangrenous lesion of the foot typically, and have a very closer look of this case. And what are 4 to 5 points you need to remember for the tomorrow's NEET PG exam, and what kind of underlying vascular lesion has led to this dark colored lesions, basically. Yes,
So
doctor.
now we can see that this patient's distal toe is affected in one foot, and the other half of the foot is affected. So the dark color shows that the dark color, along with a very well-defined border between vascular area and non-vascular area, this shows a classical Buerger's disease that is associated with smoking, commonly seen in young males. This patient requires amputation, unfortunately. This patient also has to be advised to stop taking, stop smoking, because the only way to prevent further damage, further progression of thromboangiitis obliterans is to stop smoking.
So basically, it is an inflammatory occlusive disorder, unlike the atherosclerosis. Second thing is atherosclerotic condition affects the people who are above the age of 50. Whereas thromboangiitis obliterans lead to ischemia in a young individual, typically, which is a differentiator before the age of 50, and who is having the history of smoking is a very important part of the history. Now, which vasculitis will present with this kind of lesions, doctor?
First of all, aphthous ulcer is very common in the general population. Usually, they don't require anything more than a non-specific treatment. Symptomatic relief, topical lignocaine is more than enough. However, when concerned with a vasculitis presenting with this kind of lesion, maybe the patient has these lesions multiple times. You have to suspect Behcet disease, Behcet. That presents with oral and genital ulcers. Ulcers are usually very painful, and the patient also has other kind of features, skin involvement. So treatment is again steroids.
Very good. So, in fact, one of my patients, his name is Raghava. So he's a he was about 38-year-old, and he presented with recurrent orogenital lesions. So, lot of people outside in the general clinical practice, somebody with orogenital ulcers means, अच्छा ये रेड लाइट एरिया गया, इसको सिफिलिस के लिए टेस्ट करो, एसटीडी के लिए टेस्ट करो, गोनोकॉकस के लिए टेस्ट करो, बोल के सारे एसटीडी टेस्ट, not one time, almost all 12 times, different clinicians have tested. He has orogenital ulcerations. The name Raghava means Lord Rama. So he says, sir, I know only one wife and one life. I never know any red light area, but all the doctors are evaluating. I'm fed up with this orogenital ulcerations. Do something. That is the first case of Behcet's disease that I have seen in the clinical practice. Of course, after that, so many other patients, so many other times, but always remember, first time when you make the diagnosis, that is the experience that remains with you throughout the life. The same diagnosis you will be making so many times in so many different shapes and colors. So, but most important thing is, general medicine means Sherlock Holmes. You should never be contented, especially when the patient is not improving and recovering, because it is only observation, relentless reasoning about the case, constantly thinking about the case is the most right way of becoming a sensitive and a good physician, basically. So, immune-mediated systemic vasculitis, recurrent painful orogenital ulcers. Erythema nodosum. What is meant by erythema nodosum? Erythema nodosum, pathologist के भाषा में बोलना है तो paniculitis is the name. That is, the subcutaneous fat tissue develops inflammation. That's called paniculitis. So, erythema nodosum-like lesions are typically seen. Even ocular lesions, uveitis and blindness, posterior uveitis. Arthritis will be seen. And typically, colchicine is considered to be the initial treatment, generally very responsive to colchicine, especially the pain and ulceration become resolved very fast. A lot of times people will put a Zyte ointment, they will put butter, so many things they try. Some will put sucrol syrup in the mouth and rinse it. But the moment you give colchicine, it relieves the pain and ulceration dramatically. Then immunosuppression is the main part of the treatment for any other vasculitis. Now, doctor, you see the guide of this patient. The way the patient is titubating her head and thumping on the floor. You can see how she is just like a magnetic stump, as such, the foot is stamping onto the floor. And that is what you can be able to see. And yes, so you have a patient like this, and you are able to see image geology. So what is your comment, doctor?
Yeah, so now in this patient, you look at the gait that is already very clearly abnormal. On top of that, you can see that this patient has lesions in the cortex. There are lesions around the corpus callosum. There are lesions in the pons. There are spinal cord lesions. So there are lesions all over the brain multiple times. So along with that, in the image B, you can see the classical perpendicular lesions to corpus callosum, which is called Dawson's finger sign, very specific for multiple sclerosis.
Absolutely. For the multiple sclerosis, and what she is having is a cerebellar guide. That's what you're able to see. And why multiple sclerosis is called multiple? Because the multiple sclerosis involves the spine. The multiple sclerosis involves corpus callosum. Generally, corpus callosum is bilaterally vascularized. That is the reason, unless both the sides vessels are affected, a corpus callosum normally does not develop infarct. So these infarct-like lesions, if you are able to see in the corpus callosum, that is purely because that is only possible in the case of the multiple sclerosis is what you need to remember. In the cerebellum also you are able to see the presence of all this foliated structure is the cerebellum, doctor. So you are able to see the presence of demyelination, which is classical of multiple sclerosis. In the CSF you find oligoclonal bands. MRI is very sensitive. And visual, auditory, brainstem evoked potentials are a very sensitive way. A lot of times patients will present it. And another important thing in multiple sclerosis, spaced by time, spaced by geography, spaced by geography, spaced by severity. This is what you need to remember. That is geography. One lesion in the cerebellum, one lesion in the spinal cord, one lesion in the corpus callosum, spaced by geography. Time. All lesions won't develop same time. They develop over a period of time. The person will say, initially we'll only have optic nerve involvement, for example. So there will be only blurring of vision with optic neuritis. After a few days, the patient will start having an altered guide. And another few days, the patient will develop dysphagia. So that is how there is a progression of the neurological symptoms spaced by time, spaced by geography, spaced by severity, which defines the multiple sclerosis is what you need to basically remember.
Another point I would like to add that those criteria form McDonald's criteria. This is also asked in multiple sclerosis, multiple. So McDonald's criteria spaced in time and spaced in geography. That is diagnostic of multiple sclerosis. So in order to prove the dissemination in time and dissemination in space, there is so when a patient comes to you for the first time with some or the other focal neurological deficit and you are not sure whether or not this is multiple sclerosis, it is always worth getting brain imaging done. So on imaging, if you are able to find a previous lesion which does not have any particular history associated with it, but you are easily able to prove that this lesion was present on imaging, and that itself satisfies your McDonald's criteria, and you can diagnose multiple sclerosis in the first presentation sometimes. So that is a very important point to note.
Very good. And another important thing is Trigeminal neuralgia, very important presentation of multiple sclerosis. Generally, trigeminal neuralgia presents after 45. After 45. And very commonly, it is the varicella zoster, the chicken pox, which is getting reactivated, is generally presentation, underlying cause of a trigeminal neuralgia. But what is the important aphorism that you need to remember? Any young patient, 25, 20 years old, presenting with trigeminal neuralgia, you should always have a high index of suspicion for the presence of multiple sclerosis is what you need to basically remember. Now, doctor, this patient, right. This patient, you observe the eye. Yeah, 1 minute. Yeah. So you observe the eye. He is able to move upwards, downwards, but not side. Side to side movement is not there. Upward or downward, he is able to move, not side to side. He can also blink his eyes. He can be able to blink his eyes, very important. And he was asked to close his eyes if he understands what you are talking. Yes, he is blinking his eyes. That means he is able to understand what you are talking. Understand what you are talking. Right? And you asked him, you close the eyes when you feel the pain when I pinch. He is able to do that. That means his sensorium is also intact. With the intact sensorium, with the quadriparesis, none of the limbs he is able to move. Only retained thing is the vertical movement of the eyes. Nice. And given this MRI, what is your diagnosis, doctor?
So this patient is having pontine involvement clearly visible here. So pontine involvement with being locked in, that is very specific for being central pontine myelinolysis. Unfortunately, central pontine myelinolysis is a completely preventable condition. It should never happen in a hospital. I hope that all the students who are watching this never cause CPM in their patient. CPM is caused when a patient with hyponatremia is very aggressively corrected. It causes demyelination of the central nervous system. A patient motor system is affected first. This is unfortunately uncurable. It was completely preventable, but it happened. One point to note is that a very serious concern should be in patients with diabetes insipidus. They should never be given normal saline for whatever reason. They have to be given fluids. Always give them either 0.4 half normal saline or give them D10, D25, but never give them normal saline, because a normal saline will cause CPM in a diabetes insipidus patient. Ideally, in a 24-hour period, the sodium correction should not be more than 10 milliequivalents per liter. If more aggressive correction is required in case of patients of symptomatic hyponatremia, patients having hyponatremic seizures, then we can correct it up to 15 or maybe up to 18 maximum. But that would also be a little too much. Ideally, if a patient has asymptomatic hyponatremia, just correct the cause, do not correct the hyponatremia to prevent complications like this.
Absolutely. And one important point you need to understand is pons and thalamus. इसका इम्पोर्टेंस क्या होता है ब्रेन में? ब्रेन ऐसा जगह है, इट इज लाइक दिल्ली में मोदी जी का सरकार. इट इज लाइक दिल्ली प्राइम मिनिस्टर ऑफिस. इस ऑफिस को इंफॉर्मेशन लाने वाले रहते हैं, इस ऑफिस से इंफॉर्मेशन लेके बाहर जाने वाले होते हैं. सो इन सब जो भी इंफॉर्मेशन उसके अंदर जा रहे हैं और बाहर निकल रहे हैं, उसको प्रोसेसिंग करने के लिए यहाँ एक चौकीदार बैठ के रहता है. He is called the Center for Differentiation and Center for Afferentiation. Center for Afferentiation. इसका मतलब है whatever that is going to the cerebral cortex, afferent sensory information invariably need to pass through the thalamus. So thalamus is the ultimate center of afferentiation. All sensory input invariably need to pass. The only exception is olfactory. Other than olfactory, everything else invariably touches the thalamus and passes to the sensory cortex. That is what we need to remember. Second point you need to know is all the differentiation. Oh, sometimes all the differentiation. 1 minute. All the differentiation. Typically, whatever that is leaving the brain and going to all our muscles, it need to invariably pass to the pons. So pons is called the center of differentiation. अगर pons में कुछ दिक्कत हो गया तो दिमाग समझ सकता है क्योंकि differentiation is not affected. But दिमाग जो commands नीचे दे रहा है वो स्पाइनल कॉर्ड को जाने से ये pons में ब्लॉक हो गया. इसलिए इस आदमी समझ रहे, आप जो बात कर रहे हैं समझ रहे, मगर उसको रेस्पॉन्स देने के लिए he is not able to give the response. He is not able to move any of his limbs. He will be lying down on the bed like a frog. Now you will ask me a question, sir. वो अपने आंखों, the eyes, he is able to move vertically. No, sir. Why then? Why is it happening? You should remember the center for the vertical gauge is located in the midbrain, not in the pons. So that is the reason the only motor activity that will be left over. अगर pons को दिक्कत हो गया तो the only motor activity that will be left over is vertical eye movement is what you need to remember. That's the reason this patient is only having vertical eye movement, no horizontal eye movement. Sensory perception is intact, but he is having quadriparesis and all other motor activity is completely paradigm. That's the point you need to appreciate in the neurology. Now, doctor, what is the organism implicated in Guillain-Barre?
So the most common organism would be Campylobacter jejuni. It will start after a GI infection. Probably patient will give history of diarrhea 10 to 14 days back. Other than that, there are multiple other organisms: upper respiratory tract infections, lower respiratory tract infections, vaccinations. A lot of vaccines, particularly in current times, COVID itself, as well as COVID vaccinations, are causing Guillain-Barre syndrome. So that is another thing to note. However, Campylobacter jejuni is most common. Second most common, if given after a respiratory infection, would be Mycoplasma pneumoniae.
So Guillain-Barre is post-infectious demyelinating polyneuritis, and typically it is polyneuritis. That means the nerves are demyelinated. That's the reason you get all the LMN features. That is the reason it presents with acute flaccid paralysis. That's the point you need to basically appreciate. And it is an ascending paralysis. That is, the distal weakness is first, followed by gait disturbances. And ultimately, what is the main challenge whenever a Guillain-Barre patient is admitted to your hospital? Ventilator तैयार करो, ventilator तैयार करो, ventilator तैयार करो. So, आप ventilator तैयार करके बैठना पड़ता है if at all the patient of Guillain-Barre is admitted to you. All of you know albuminocytologic dissociation, increased protein with little pleocytosis, that is albuminocytologic dissociation. Now, one of the very important things you need to remember is there is a Miller-Fisher variant of this Guillain-Barre. There, the main thing is the ocular involvement is seen.
So the Miller-Fisher syndrome will present with a very classical triad, that is ataxia, areflexia, and external ophthalmoplegia. So ataxia, areflexia, and external ophthalmoplegia. Another important thing to note is that areflexia is very classical in all GBS patients. The point is that the afferent impulses for your deep tendon reflexes are through your muscle spindle, which are supplied by very heavily myelinated nerve fibers. So GPS will involve those early. That's why one of the earliest features would be a loss of reflexes, and one of the latest features to resolve will be a loss of reflexes. There are multiple variants of Guillain-Barre syndrome. The most common variants will have predominantly motor involvement with very late bowel and bladder involvement. Autonomic involvement may or may not be present. Sensory involvement is also seen. So depending on that, you could have either axonal myelopathies or you could have demyelinating diseases. And treatment is either IVIG or plasmapheresis. IVIG is basically your IV immunoglobulins, which are going to saturate your FC receptors and prevent further demyelination. Whereas plasmapheresis will remove your acute antibodies. Mechanism of Guillain-Barre syndrome is also asked, which is molecular mimicry. And I think that should be more than enough for NEET point of view.
Very good, very good. In fact, IgA deficiency, IVIG is contraindicated if a patient is having IgA deficiency. See, one of the, on a lighter vein, during our NEET PG preparation, reading Harrison, we think that we know medicine, but reading a medicine textbook is never medicine, honestly. That's the reason I always tell the NEET PG aspirants, don't become ambitious. My OB पढ़ना, ये भी पढ़ना, वो भी पढ़ना, इतना घंटे पढ़ना, जरूरत नहीं है, क्योंकि पढ़ने से आप सर्जन थोड़ी बनेगा, right? So, in the context of Guillain-Barre, I still remember one of my patients. He has a significant autonomic dysfunction, and what is the treatment of Guillain-Barre? Basically, we try to manage him with IV immunoglobulins and plasmapheresis we will do. I still remember that patient. Plasmapheresis कैसे करते हैं आप? Plasmapheresis का मतलब होता है एक मशीन रहता, मरीज रहता, इनके पूरे प्लाज्मा को लेके मशीन में डाल के उसमें घुमा के फिर प्लाज्मा को हम उसके बदन में चढ़ाते हैं. Imagine a patient who has an autonomic dysfunction and you managing plasmapheresis for him. Why? Why is it a challenge? In autonomic nervous system, the moment you take out around 200 ml plasma from the body, normal person में क्या होता है? Vasoconstriction होके BP maintain होता. But in a patient with autonomic dysfunction, the blood pressure suddenly falls when you move the plasma into the machine. You need to see that you are having enough inotropic support to maintain the BP. Once more, when you send the plasma back into the patient's body, the BP will shoot high, but you need to manage that scenario. So it is not that easy as giving plasmapheresis in a Guillain-Barre and managing on a night duty as a resident. It's not same as reading Davidson or any son for that matter. Aapka grandson निकलेगा. So in order to, by the time early morning, it is you save the patient. So that is the reason, doctor. Be very concise while you are preparing for entrance. Don't go into an infatuation that you are becoming very knowledgeable. You won't be knowledgeable. All things are trash. Entrance खत्म हो गया, top rank आ गया, जो भी seat मिला, उस branch का you have to go very, very deep. But in order to get the seat, 5 points, 10 points about each condition, you need to know it like a parrot. And imagine a lot of things. Probably today it is more easier to imagine because all the atlases, all videos, everything is available on the YouTube, right, doctor? Now, what is the autoimmune neuromuscular disease with antibodies against the postsynaptic neuromuscular junction?
So now this is very classical of myasthenia gravis. Patient comes with ptosis earlier and eventually has a muscle weakness. You can give adrophonium to diagnose it. If there is improvement, then that is very much classical of myasthenia gravis. a very close differential of myasthenia gravis is Lambert-Eaton syndrome. Lambert-Eaton syndrome is actually a tumor. I mean, it is a paraneoplastic syndrome, which also comes with weakness. The classical difference between the two, which is always asked in NEET, is that upon repeated stimulation, the myasthenia gravis patient muscle will get weakened, whereas the Lambert-Eaton syndrome muscle will get stronger. So there will be an improvement in response in Lambert-Eaton syndrome, whereas in myasthenia gravis there will be a decrease in response. I think myasthenia gravis. Another thing that is asked is that which tumor is involved in myasthenia gravis syndrome in myasthenia gravis. So that is a thymoma. In Lambert-Eaton syndrome, the tumor involved is your small cell lung carcinomas, and treatment for myasthenia gravis. Obviously, you can try a thymectomy, and you can give cholinergic agents.
Very good. So, one very classical question asked in the entrance exam is how will be the deep tendon reflexes in case of myasthenia gravis versus the Lambert-Eaton syndrome? So, you should remember that myasthenia gravis में प्रॉब्लम क्या कहाँ हो रहे हैं? आपका स्पाइनल कॉर्ड से निकल रहा है नर्व आ गया न्यूरोमस्कुलर जंक्शन को, न्यूरोमस्कुलर जंक्शन के पास आने के बाद यहाँ प्री सिनेप्टिक पोस्ट सिनेप्टिक रिसेप्टर्स आर देयर. सो यहाँ प्री सिनेप्टिक वेसिकल से एसिटाइल कोलिन निकलेगा. सो इन द केस ऑफ द myasthenia gravis, स्पाइनल कॉर्ड में दिक्कत है क्या? नहीं है. नर्व में दिक्कत है क्या? नहीं है. प्री सिनेप्टिक में दिक्कत है क्या? नहीं है. कहाँ है? पोस्ट सिनेप्टिक रिसेप्टर में दिक्कत है. So a LMN is defined as, from there it is defined Anderson cell, then nerve until presynaptic receptor you call the LMN. Whereas postsynaptic receptor is not LMN. So that is the reason reflexes are characteristically normal. Deep reflexes are normal in case of myasthenia gravis. Whereas in Lambert-Eaton, the presynaptic receptors are destroyed by the autoantibodies. So that is the reason they are called yo-yo antibodies, right? So the antibodies against calcium channel on the presynaptic receptors are affected. That is the reason एरिफ्लेक्सिया कहाँ होता है? एरिफ्लेक्सिया होता है ईटन लैम्बर्ट में. नॉर्मल रिफ्लेक्सेस होता है myasthenia gravis में. This is the favorite MCQ in the tomorrow's NEET PG exam, which they are going to ask you. You have to be 100% sure about. Now, the same thing. Repetitive neurological stimulation with increment of muscle response.
Lambert-Eaton syndrome.
Absolutely. Now, doctor, you see this case. The lateral arm, I mean unilaterally, one arm swing नहीं है. हम जब चलते हैं स्विंग करते हुए जाते हैं, मुझे नीट पीजी में सीट आ गया बोल के. मगर इसमें क्या हो गया? यूनिलेटरली वन आर्म में स्विंग निकल गया. और सेकंड इंपॉर्टेंट थिंग यू कैन सी हियर इज देयर इज अ freezing of the gait when the person is turning. So typically you can see a Parkinsonism patient. आप कभी एयरपोर्ट गए तो आप बहुत बार देखते हैं एयरपोर्ट में, वो he will be with the shuffling gait he will reach until that frame. हम सिक्योरिटी फ्रेम से चलते हैं ना एयरपोर्ट में, जब वो फ्रेम आता है वो फ्रेम के अंदर से वो जब जाना होता है रुक जाता है. So that is classical of Parkinsonism. Another important thing is tremor of Parkinsonism classically is asymmetrical unilateral tremor. जब tremor bilateral होता है Parkinsonism नहीं होगा. Parkinsonism tremor is asymmetrical unilateral tremor is what you need to remember. Now, few points about Parkinsonism, Dr. Dhairya.
Yeah, so Parkinsonism is a age-related condition commonly seen in older ages, 65 and above. The patient comes with unilateral involvement. There will be weakness. There will be a mask-like faces. The gait is affected. There are tremors. Tremors are resting tremors. Uh, and
Very
the
good.
treatment is with levodopa, carbidopa. So levodopa is your dopaminergic agonist. Carbidopa is your anti peripheral decarboxylase inhibitor. You can also give COMT inhibitors, that is catecholamine orthomethyl transferase. There are selegiline and rasacillin is also given, that is your MAO-B inhibitors. And I think
Brilliant.
these NMD
Then,
antagonists are given. Yeah, NMD antagonist, that is your amantadine.
good. So, eosinophilic intranuclear inclusion body is the Lewy body, which we find in the case of the Parkinsonism. And Lewy body dementias. Lewy body dementia. So, a lot of times we call Parkinson plus disease. So, Lewy body dementia is basically associated. When Parkinson's is associated with dementia, you should always remember. And another important point you need to know is what is the close differential diagnosis of conditions like Parkinsonism, associated dementia. You have frontotemporal dementia is one thing. Then when the people become elderly, they develop vascular dementia is another important dementia. And once more, dementias are divided into cortical dementia, subcortical dementias, like Huntington's chorea, etc. They're all subcortical dementia. So whenever a dementia plus a movement disorder, you call subcortical, and the other are cortical dementias. So one good news that I like to, am I audible? Yeah.
Yes, yes.
One good news I like to share with all our audience is we have friends across the world. Some of my classmates, some of our earlier students, they're top consultants in California, New York, some are in Australia, UK, some of the top hospitals they are working. I told the guys, hey, what is the use of you bloody fellows? You have done in PGI Chandigarh में अपना MD किया और एम्स में MD किया, जाके कैलिफोर्निया न्यूयॉर्क में बैठ गया, आपसे क्या फायदा है इस देश को? उसने बोला अभी बोलो मुरली भाई, what else can we do? I said come into my live show. So one of my very good friend, Dr. Sampar, he is in Cincinnati. He's a gastroenterologist. Similarly, I have another friend, Dr. Narendra. He's a neurologist in the Stanford. So I invited them to join for a. They're all once upon a time MD entrance toppers, later USMLE toppers, and now they're top clinicians in America. So I said, please join. We will have 1 hour chai pe charcha with Dr. Murali Bharadwaz while all our online students are there, and we will have a judal bandi and a small consultant to consultant fight on some of the USMLE styled clinical cases. So you are going to have more and more number of these sessions with some of the best top consultants globally, not only in India, who will be more than happy to share a 1 hour session and discuss around 30 to 40 questions, and that will add a lot of fun in learning, right? So, doctor, what are Parkinsonian syndromes?
So now these patients who have Parkinson-like features but not primary Parkinson's disease are called Parkinsonian syndrome. So if the Parkinsonism is primary or idiopathic, then you call it Parkinson's disease. Everything else is called a Parkinsonian syndrome, where you have extrapyramidal involvement without being idiopathic. So you have these genetic conditions, you have prion diseases, you have toxins. So these patients are unfortunately not going to respond to your dopaminergic drugs, and
Very
that's
good.
about it.
So Huntington's, Scheidegger, Creutzfeldt-Jakob, Wilson, in all this, as Dr. Dhairya rightly said, extra-pyramidal features like rigidity, echinacea, and tremor, etc., etc. So all of you know, spasticity is pyramidal.
Pyramidal.
Rigidity,
Rigidity.
extra pyramidal. And what is pyramidal tract? Corticospinal tract is pyramidal tract. And what are extra pyramidal tracts? There are 4 tracts: vestibulospinal,
Rubros.
tectospinal, rubrospinal, reticulospinal. So vestibulospinal, tectospinal, rubrospinal, reticulospinal. ये चारों को बोलते हैं extra pyramidal. And why they will what is the difference between rigidity and spasticity? Spasticity होता है अगर आप, if you are trying to extend a joint, initially there is a resistance, after that there is a giving up. It's called clasp knife quality. Whereas rigidity में क्या होता है? Throughout the movement you are having resistance, which is called lead pipe quality. And one important point you need to remember is why there is a spasticity in pyramidal and rigidity in extrapyramidal, because you have agonist muscles, antagonist muscles. Both of them, the tone increases in case of extrapyramidal lesions. Basically, spasticity and rigidity are a sign of what? Tone. They are not the sign of strength. Please, a lot of students have a confusion. Strength अलग होता है, tone अलग होता है. अगर आपको hemiplegic limb है तो, अगर hemiplegia है तो, hemiparesis है तो, किसके बारे में बात कर रहे हैं हम? Weakness के बारे में. Whereas spasticity rigidity का होता है increased tone conditions. But the increased tone affects both agonist and antagonist equally. That is how you get rigidity in case of extrapyramidal. Whereas agonist or antagonist selectively is more affected in the case of the spasticity. One of them is more affected than the other. That is the reason you get that clasp knife quality in case of spasticity, is what you need to remember. Now, doctor, what is that neurological degenerative syndrome which has got Parkinsonism plus autonomic dysregulation?
So now this patient with Parkinsonism and autonomic dysregulation, I would say, is it Friedreich's ataxia?
It is Scheidegger syndrome. So Scheidegger is Parkinsonism plus autonomic dysfunction with widespread neurological signs like cerebellar, pyramidal, and LMN lesions is what you need to remember. So what is the treatment of Parkinsonism, doctor?
The first thing is your levodopa, that is your dopaminergic agonist. It is never given alone because there is peripheral decarboxylation. That's why you have to give it along with carbidopa. Other than that, I already explained all the other medications, I think. So dopamine agonist, that is your bromocriptine, MAO-P inhibitors, that is selagelin and rasagelin. COMT inhibitors, that is catecholamine orthomethyl transferase, that is entacapone and tolcapone. Your NMDA inhibitors, that is amantadine. Central anticholinergics such as galantamine and benztropine.
Very good.
These are
Now, this patient's pedigree is being shown to you, and he's also having dementia. So, what is this pedigree? Is it autosomal dominant or autosomal recessive or X-linked recessive or X-linked dominant? If so, why?
So now always people are always confused. How do we differentiate whether or not it is dominant recessive, X-linked, Y-linked? We don't know anything. So I think that it is a very easy way to. I'll just teach a very easy way to do it. So first you look at male. So now in the first slide you can see the male number 4. That is his wife is not affected, but he is affected with the disease. You look down in the second generation. So the male 4 has affected male 9, but has not affected the female 8. So that would mean that the disease has transferred from male 4 to male 9. Uh, the only chromosomes that transfer from a male to male would be the autosomes and the Y chromosome. So this could either be an autosomal dominant disease, or this could be a holandric disease, that is a Y chromosomal disease. Now you look on the left side and you see that a female is affected, that is female number 2 and female number 6 are also affected, which means this can absolutely not be a Y-linked disease. So that just leaves you with the other remaining option, that is that this disease is an autosomal dominant disease. So
Good.
now an autosomal dominant disease presenting with dementia, very classical of Huntington's chorea. A very important thing to note about Huntington's chorea is that it is a trinucleotide repeat disease. That is, there is on chromosome 4 there is a repeat of CAG trinucleotide. The patient presents with worsening dementia. There is also Parkinsonian features and psychiatric features as well. Another very important point to note is anticipation. That is, the disease presents earlier and earlier in successive generations. So if a mother has it at 40 years of age, the daughter will have it at 35 years of age, and then her son will have it at 30 years of age. It is classical of all trinucleotide repeat diseases. Others are your Friedreich's ataxia and your Fragile X syndrome.
Good. So basically here, both men and women are affected equally. That means it is not X-linked. That is what we can be able to understand. And second is it transmitting horizontally or is it transmitting vertically down? So there is another clue to say that it is a dominant trait basically. So that's how it is the autosomal dominant. So very good, doctor. There are many more questions to discuss, but we are limiting the session to a 1 hour session. So thank you very much once more for Dr. Dhairya for giving his time, and in spite of almost how many night duties, Dr. Dhairya?
Usually around 2 at least per week.
See,
Sometimes, and yeah, so it's
हम इतना मेहनत करके MD में सीट आने के बाद almost you will have no time to sleep with anyone but only with your duty. So that is the reason a lot of times students ask, sir, seat आने के बाद शादी करना या अभी शादी करना? So always my advice is, पहला तो शादी करो, एक काम तो हो जाएगा. So बाद में कैसे भी सीट आएगा, सीट आने के बाद कैसे भी वो दूसरा शादी होता है ड्यूटी के साथ. So that's the point. So thank you very much to all of you. And once more tomorrow, we are going to have a group discussion session. Around 7 to 8 students who are also preparing for NEET PG exam. If you also want to participate into this live stream and then take the challenge of being a part of a group, randomly answering around 200 questions in a rapid fire, please do call our helpline 9000868356, and that will give a opportunity for you to become live broadcasted. And we will have a 2-hour session, evening 6 p.m. to 8 p.m. A couple of hours of session. We will finish 200 questions around teacher versus 9 students concurrently, and then one after other, we will have a rapid fire of answering. For every question, whatever points that come to your mind, you can speak out in the broadcast. So that's the plan. Thank you so much, Dhairya, and we wish to see many more sessions along with you.
Thank you for having me. This was a lot of fun, and I hope to see you again in the future. Another thing is I would like to discuss COVID in the future sessions. So we'll probably arrange that if the students want it. So thank you again. Thank you for listening, everybody. Have a good night.